I will talk to you briefly about a trial that is close to being opened on using Actimab as a bridge to transplant for patients with P53 positive myelodysplastic syndrome. Why P53 positive myelodysplastic syndrome? It seems quite obvious. It's a very unmet need, and I'll show you some data to support that. So I'm on one side of the street, and surgery is on the other side of the street. Myelodysplastic syndrome, as you all know, a disease of the elderly, a common disease, more than 100,000 cases according to this estimate here. A disease with a variable prognosis. Some patients are quite indolent, but many are quite aggressive and ultimately die of the disease. The only curative option is an allogeneic transplantation, and as many of us know, it is far from satisfactory. We categorize these patients by the International Prognostic Scoring System. I'm not telling you anything new here, based on cytogenetics, bone marrow blasts, hemoglobin, platelets, ANC. We assign scores to each of these markers, and a score of greater than 6 is very high. A score of 1.5 to 3 is low, but even low is pretty bad in my opinion. Half of these patients have died within 5 years. I believe these scores tend to be underestimated, and it could be argued that most of the patients are in need for better treatments. What are these treatments then? The treatments can be supportive care, not very gratifying if you're in one of these categories. Even when you're 60, many of us are getting close to that or over that, and it sounds awfully young these days. And one can use hypomethylating agents, which have been used now for the last decade and a half. Can induce remissions, can prolong survival somewhat, but are far from curative. One can also use, obviously, more intensive leukemia-type treatments, but they are more toxic, poorly tolerated by the older. One can use stem cell transplant, but it has its own problems. Stem cell transplant can be given in very high doses, what we like to call myeloablative conditioning, and then are poorly tolerated, or can be used in reduced doses, because about 20 years ago we figured out that we could get away with that. We could give fludarabine, and we could get cells to engraft. There was a wave of enthusiasm, and there continues to be, but we've also learned that the reduced intensity conditioning regimens have high relapse rates and have their own problems. We categorize further the patients based on their age, somewhat, although we like to go away from that, and we like to talk more and more about their fitness versus their frailty, and fitness versus frailty as defined by a number of comorbidities, but also by the way people live. There's plenty of patients now with many comorbidities, have had heart surgery, have had prostate cancer, and are living very healthy lives and coming skiing here in Utah. So fitness is more than comorbidities. Fitness is also, it's a mental issue. It's an issue of being active, and we are learning a lot about these. And my former colleague at the University of Chicago, Andy Arts, has done a lot of work in that field, and there's others who do this. There's also, as I treat more and more older people, there's also a mental fitness, and we are learning or only scratching the surface. But what I want to talk about a little bit is the mutations that now are becoming important. And this trial, the trial that I will discuss here, is built a lot around the concept of the prognostic value of mutations. We have known for years that cytogenetics matter. And cytogenetics, after all, are a way of detecting molecular mutations under the microscope. And some very giants in the field, Janet Rowley among others, have really opened up this field and have made us aware of the importance of this. And it's fitting, since we talk about melphalan, which is a 60-year-old drug, that we are still discovering novelties about, that we pay tribute to all these people that really opened up the field. And cytogenetics opened this up, and now we have molecular tests, and we do mutation analysis. And many of you, this is just a slide to tell us that we are doing more and more transplants that's in part for myelodysplastic syndrome, and that's in part because older people are fitter. Older people, there are important reductions in toxicity thanks to supportive care. But and there's more interest in transplant, but the results are not always good. When talking about mutation, somebody was asking here, P53, what does it mean? And P53 is a tumor suppression gene, cannot pronounce that is present in about 20% of patients with MDS. There's other genes, and I cannot read it from here, but they are now well in our other mutations. We are all familiar with them now. ASXL1, NMDP, TET2, RUNX1, either mutations in transcription factors or mutations in epigenetic modifiers. But I will try to convince you that P53 is one of the more important ones. And looking at the top part of this curve, this is from an abstract presented by a consortium of 6 institutions and presented by my colleague Sang-Min Lee from Cornell. They looked in 963 newly diagnosed MDS patients at the prognostic relevance of 6 of the most common molecular mutations, including the ones I mentioned, ASXL1, DNMT3, TET2, P53, and I forget what the 2 last ones were. They found that actually for prognostic purposes, by far the most important one was P53. It was a very, very adverse prognostic factor, and patients with a P53 mutation had 2.5 times worse survival than all the other ones. That did not apply to the same degree to any of the other common mutations. Why does it talk here about moderate impact or high impact? I actually had some trouble figuring that out myself. I had to read the abstract again. But one now looks at subsets of mutations, and there's prediction algorithms for how important a mutation is going to be and how much a particular mutation in P53 will affect its activity. Turns out that most of the mutations in P53 were considered moderate by these prediction algorithms. About 2% were considered to have a high impact. In reality, it didn't matter whether they were of moderate impact or of high impact as predicted. They both had equally poor overall survival and equally strong adverse prognostic prediction value. That is with the newly diagnosed patients with MDS. Why don't we transplant them all? And what happens if we transplant them? This is from a paper in the New England about a year ago now, where they did the same thing, predicting outcome of patients undergoing allogeneic unrelated donor transplant, if I remember correctly, and tried to define molecular and cytogenetic predictors of outcome. And they found again that despite transplant, P53 mutations were extremely adverse factors. And we know that now. We've learned that in the last 3 or 4 years since we routinely do these mutation analyses. When we get a P53 mutation patients, we are exceedingly worried. And I think all of us here who are transplanters have learned to deal with the adverse impact. So a major unmet need, how to do transplants. I should add to this, the major reason why these people fail is not so much transplant-related toxicity, but it is disease progression. So this consortium of 6 institutions, Cornell, Cleveland Clinic, Hopkins, Moffitt, Dana-Farber, and MD Anderson, consortium studying MDS has proposed this trial in collaboration with Actimab, and Gail Robos, my colleague, was supposed to give this talk, but she's traveling somewhere in the world, so I'm giving this talk for her. And the rationale is that we CD33 as expressed in 75% of the MDS patients. We hope that we can add Actimab to the conditioning regimen. You've heard already that the drug has very limited extramedullary toxicity, is overall well tolerated, and we focus on the subgroup of patients with P53 mutation. So the rationale then again is that we don't want to do myeloablative conditioning. Patients are older. Patients will not tolerate the extramedullary toxicities. We don't want to use regular reduced intensity conditioning because there's too much relapse. So we combine Actimab with a reduced intensity conditioning, and we hope that we will avoid the extramedullary toxicities of the myeloablative conditioning, that we will have a very targeted anti-MDS effect, and that ultimately we will obtain improved survival. This is the trial, and you've seen a similar slide from Sergio. The biggest difference here is that the dose of actinium. We give a dose of actinium here that is twice of what has been given in other trials. We administered this dose, and then about a week later, we come in with our reduced intensity conditioning, followed by an allogeneic, either related or unrelated donor transplant. The trial is supposed to have 60 patients. We believe that's easily feasible with those 6 institutions participating. And the efficacy endpoint is going to be the survival at 1 or 2 years after transplant. So, details of the trial. It's going to be a phase 2 trial, open label. As mentioned before, it should have about 60 patients. Prior treatment is allowed with hypomethylating agents, diagnosis of MDS. There's a requirement for having greater than 25% cells that are CD33 positive, which is the majority of patients with MDS. Patients have to be 18 and above. I expect that they will mostly be in their 60s and 70s, and they have to have a TP53 mutation. And that's it.